Welcome, everyone. Thank you for joining us for this webcast, Non-Medical Switching, the Harmful and Unintended Consequences Affecting Patients, sponsored by AIMED Alliance and the Partnership to Advance Cardio Health. This webcast has been pre-approved for HRCI and can be submitted for SHRM credit. Please be sure to attend the complete webcast in order to receive your credits. If you have any questions during the webcast, click on the Q&A tab in your webinar controls and type them there. A new tab will open in your browser with the webcast survey. Please be sure to complete it as soon as the webcast has ended. It is now my pleasure to turn it over to the Partnership to Advance Cardio Health and AIMED Alliance for their presentation.
Everyone, good afternoon. Thank you so much for joining us today for this webinar on non-medical switching and the harmful and unintended consequences affecting patients. My name is Ashira Vantries, and I'm a staff attorney at AIMED Alliance. AIMED Alliance is a 501c3 not-profit health policy organization, and our mission is to protect and enhance the rights of healthcare consumers and providers. We're excited to collaborate with the Partnership to Advance Cardiovascular Health to put on this webinar today. The Partnership to Advance Cardiovascular Health is a nonprofit that works to advance public policies and practices that result in accelerated innovation and improved cardiovascular health for heart patients around the world. I would now like to turn it over to Ryan Gooch from the Partnership to Advance Cardiovascular Health.
Thank you, Ashira, and thank you so much to the AIMED Alliance for partnering with us to produce this webcast. To our West Coast viewers, good morning. To our East Coast viewers, good afternoon, and happy Tuesday to everyone. Thank you all for joining us for this discussion on non-medical switching and how it affects cardiovascular patients. Before we get started, just as a programming note, today will be a very conversational presentation, so please feel free to send questions in the Zoom chat, and I will do my best to offer them to our panelists throughout the presentation, and also at the end, we will have a few minutes for questions as well, so if you'd like to wait till the end, that's fine as also. We're excited to bring you all the perspectives of heart doctors and heart patients and a benefits professional who have a unique perspective on heart disease and how best to treat it. Our program topic is about an issue that might seem like a niche topic, frankly. However, I will say that the issue of non-medical switching, which we're going to discuss today, affects literally hundreds of thousands of cardiovascular and cardiometabolic patients every single year. This issue also affects people outside of the cardiovascular space. Patients are regularly switched off of medications which they were stable on initially, and the consequences can be disastrous, not only for cardiovascular patients but for other patients as well. My name is Ryan Gooch, as Ashira said, and I am the executive director of the Partnership to Advance Cardiovascular Health, or PATCH for short. You can see PATCH's mission here on the screen. Ashira shared it as well. We work to advance public policies and practices that accelerate innovation and improve cardiovascular health for heart patients. Now, in practice, PATCH is a patient advocacy organization. We're a nonprofit, and we work to galvanize dozens of clinician and patient organizations on policy issues that affect access to appropriate cardiovascular care. You can see a number of our partner and ally organizations here on the screen. Now, if I were to summarize PATCH's goal, it is to support the clinician-patient relationship. And we do that because we believe that doctors, nurses, and their patients know each other best, and that appropriate care is the care that is closest to the doctor and the patient. We work to empower clinicians and patients to speak up when barriers to appropriate guideline-supported care are impeded by public policy. Now, in our mind, public policy can mean laws and regulations passed by a state legislature or by the federal government. But importantly, we also view public policy as policies that are implemented by health plans and their pharmacy benefit managers as well, which is the case for what we're going to talk about today. Now, before I go further, I'd like to introduce our speakers, and first of all, thank them so much for making themselves available to us, because I know they are extremely busy professionals. So we have three panelists today. We will hear from Dharmesh Patel, Dr. Patel is a cardiologist from Memphis, Tennessee. He is president of the board of my organization, the Partnership to Advance Cardiovascular Health, and he practices at the Stern Cardiovascular Clinic in South Haven, Mississippi. He also serves on the Southeast Board of the National Lipid Association and on the national board of the American Society for Preventive Cardiology. Our patient representative today will be Beth Waldron. Beth is an independent patient advocate from Chapel Hill, North Carolina. In 2003, she'll tell you about this a little bit later, she experienced a life-threatening deep vein thrombosis and pulmonary embolism, which were initially misdiagnosed. And as a result of that experience, she began working towards greater thrombosis education for both patients and healthcare professionals. She resides in Chapel Hill, North Carolina. And finally, we will hear from Patsy Reitzman. Patsy is the healthcare and benefits professional from Franklin, Tennessee, just outside of Nashville. Patsy started her career in healthcare in 1980, working for Electronic Data Systems, or EDS's healthcare division, while they had the contract for the Tennessee Medicaid program. With an extensive executive background in healthcare, she has directed and managed healthcare contracts and staffs in Tennessee, Arkansas, Kansas, and a number of other states. She now consults and speaks nationwide, informing, educating, and equipping businesses, individuals, providers, and of healthcare and vendors about healthcare, the cost of healthcare, and provides a wealth of information about what is occurring and future trends in healthcare. Now, over the last year, we witnessed a reinvigorated conversation around cardiometabolic disease over the last 2 years, really. Principally, that's because the thing that has dominated our headlines, the coronavirus, has exacted a heavy toll on patients with diabetes or cardiovascular disease. And so I ask you to consider these facts. If you have an existing cardiovascular condition, the COVID mortality rate was nearly 40%. A recent study was published that showed that 20% of people diagnosed with diabetes who contracted COVID died within 28 days. And as alarming as these facts are, it's important to remember that even before the coronavirus brought attention to all things healthcare, cardiovascular disease and diabetes had devastating impacts on Americans and the American healthcare system. For instance, cardiovascular disease kills 700,000 Americans every single year. Every year, more than 800,000 Americans have a heart attack, and 1.5 million are newly diagnosed with diabetes. And if someone is diagnosed with diabetes, they are at a 2 to 4 times higher risk of dying from a heart ailment. And within the last few years, after decades of improvement in cardiovascular health, we've seen progress in this country begin to fade. Deaths from heart disease stopped declining and actually started to increase. Cardiovascular patients today cannot be pigeonholed as just cardiovascular disease patients. Comorbidities are on the rise in this country, and cardiovascular patients often have an assortment of medical issues, and Dr. Patel will speak to that here shortly. We are often treating cardiovascular disease, diabetes, kidney disease, atrial fibrillation, and heart failure all together when we're talking about heart disease patients today. Rarely anymore are patients siloed in just one disease state. Cardiovascular disease affects us all, and we have to begin to take it very seriously in this country. And so to illuminate the challenges we see in cardiovascular care, I want to bring in Dr. Patel first, and I'll have Beth and Patsy chime in here and there on this first discussion. So Dr. Patel, thanks so much for being here. To get us started, can you tell us a little bit about your practice in South Haven, Mississippi? Tell us a little bit about your population, what it looks like, the major challenges you face with folks today, that kind of thing, to get us started.
Yes, good morning, Ryan, and good morning to everybody on this webinar. I am a practicing cardiologist in South Haven, Mississippi, and one of the advantages I have is I'm about 20 minutes from a city called Memphis. So I have the real distinct pleasure of having patients who work within a city, and then I have the whole of Mississippi, which is the Delta, where we see patients in the rural setting. So I feel that I have a good mix of patients of both urban life and patients who are out in the Delta. And one of the things about Memphis, of course, is it has a very rich patient population. What I mean by that is about 50% Caucasian and around 40% Afro-American and about 10% Hispanic. So I feel that the patients I see every day have a really good representation of patients who unfortunately do have heart disease. And, Ryan, as you mentioned, cardiovascular disease is a major issue. It's the number one cause of mortality in the United States of America. We know that obesity is increasing at an epidemic rate. We know that 1 in 3 women die of heart disease. The fact of the matter is these patients that I see are complex, and they're not just simply having hypertension, or they're not simply having heart failure, or they're not simply having atrial fibrillation. These patients have a mix of all of the above. Treating these patients can be complex. And, we talk about guidelines. I don't treat populations. I treat patients one at a time. And so that's what makes what I do fun. But at the same time, as we're going to discuss, Ryan, there are also challenges that we face.
So, Dr. Patel, we're talking to human resources professionals today, and they're not doctors. So can you outline, when we talk about cardiovascular disease, I think that people think of heart attacks and strokes, but can you outline for us the, 3 or 4, 2 or 3 major cardiovascular diseases that you're treating most often, and kind of help us understand like what we're talking about with diagnosis, what the kind of standard treatment regimen is. Just give us a flavor for like the individual diseases you're treating most of the time.
Sure. Just like you've said on this slide here, hypertension, half of America has hypertension over the age of 50. What is hypertension? It's when your blood pressure is high, but most patients feel, quote, great. What's the number one cause of disability in America? Strokes. What causes strokes? Hypertension. What else comes into play? Diabetes. Patients that have diabetes essentially have a certain increased risk of heart disease. Diabetics are on a regimen of medicines. It can be insulin, it can be other oral tablets. And in today's society with evoluting technology, patients even take injection type medicines to lower the sugars to reduce the risk of heart disease. And then we have things like high cholesterol. When patients have high cholesterol, plaque buildup or cholesterol builds up in the vessels of the heart, causes heart attacks, or they can build up in the vessels of the neck or the leg and cause strokes or even amputations. So we're working hard on these patients, giving them cholesterol type medicines, injection type medicines to lower the cholesterol. And one point I want to make very clear today is it's not just simply one pill that fixes all. If you were to talk about these different disease states, diabetes, atrial fibrillation, hypertension, obesity, heart disease, peripheral vascular disease, it's not simply just one medicine that fixes it. Classically, it can take up to 2 to 3 different medicines to address each of these different disease states. As a cardiologist, I see patients who have heart disease, which is when there is progressive or ultimate blockage of the heart vessel. If they've had a stroke, it would be a blockage in the neck. And if they have peripheral vascular disease, they may have blockage or stenosis in the legs. It's very sobering to say that about 40% of people feel great the day they die before a heart attack. 2/3 of events are sudden. So I feel that as a provider, we have to do our very best to treat these patients who are complex with appropriate therapy to reduce the risk of tragic events.
So you're trying to prevent these events, and as you said, they can be life-altering. But can you walk us through? Give us some flavor as a current practicing doctor, clinician. What is the process of getting a patient stable on a medication? How difficult can it be? Can you talk about how that kind of journey works today with a complicated heart patient? Getting them.
Sure. I'm old enough to say that the whole paradigm of the patient, physician, or provider relationship has changed to an extent, because when I first started medicine, I feel it was a patient-provider conversation. But now in today's reality, there's 3 people in that patient room. It's the patient, it's the provider, and it's the insurance company. Each medication, Ryan, serves a role. And if you switch one, you potentially impact every other medication. It's complex. Stable management takes time. Stable management means that patients have trusted and put into you the trust that you'll do the right thing for them. Once you have a good treatment plan that works for the patient, it should remain consistent. Now, prior authorization and step therapy can take a lot of time to find what works and to get a patient moving in the right direction.
Can you talk a little bit too about adherence, Dr. Patel, and how complicated, how difficult is it to, you would assume that if you're prescribed a medication to a patient, that they just take it, but that's not necessarily the case. Can you talk about that?
Yeah, it's unfortunately not in my practice, because with what training we have, with what studies are out there, I feel that I try to give the best therapy for the patient at that time. And unfortunately, with other barriers that we will be discussing today, it's not so straightforward, because if I say, let's say, Mrs. Jones, I'm going to give you a blood pressure medicine today, which I think will get your blood pressure down the quickest, most effectively, that doesn't necessarily mean that patient's going to get that medicine at the pharmacy. There are barriers, there are preferred agents, there are insurance restrictions. It's very frustrating to see that, what we as a provider suggest for a patient, and respectfully, having been trained in this discipline for over 15 years and holding 7 cardiac different specialty boards, I feel that as a provider, I really should have some autonomy about giving my best suggestion for the best outcome for my patients.
So Patsy, thank you, Dr. Patel. Patsy, I think that Dr. Patel kind of laid out there what we're looking at, in terms of, national trends with chronic, what we're really talking about is chronic. So as a human resources professional, a benefits professional, can you kind of pull in for us your thoughts on managing and treating chronic diseases from the HR perspective? Because that's really what we're talking about here. Diabetes, heart disease, and other comorbid conditions are expensive to treat. So for the HR professional, what are the major considerations that they need to consider when talking about, chronic disease in the workforce?
A couple of things I want to mention. One is we're looking at about about $4 trillion annually on healthcare cost. And when you look at just the chronic disease management, that typical patient will cost 17 times more than a regular patient. One thing I want to reiterate is something Dr. Patel said, and that is it used to be between the patient and the physician, and they would make the decision. Healthcare is not a one size fits all. It's about the person. And one thing I'm going to talk about a little bit later are the pharmacy benefits managers and the financial component that they are getting for it, decisions they are making, and it's based upon finances that are profitable for them versus what is affecting the patient. As an HR professional, think about this. Medical bankruptcy is now the #1 reason for bankruptcy in the US, and that includes people who have insurance. So if I have a patient or if I have an employee that is going through all this that Dr. Patel talked about, they are significantly getting higher cost from their healthcare. They could go bankrupt, but it's also affecting you as a healthcare professional. And one thing I'm going to talk about a little bit later too is the hidden cost. Starbucks is now spending more on healthcare than they are on coffee beans. And I think one thing we're not realizing as healthcare professionals is we are in somewhat becoming healthcare companies who are also providing a service, but we've not known that we need to be educated in the past. So we've got to become educated, and as we go throughout, I'll provide some tips on doing that.
That's a fascinating twist on that. I had not heard that. It's really interesting to think that, Starbucks is actually a healthcare company that sells coffee beans. That's really interesting, Patsy. So, at Patch, we talk a lot about utilization management and access to treatment. And there are a number of utilization management protocols that folks on the phone may be familiar with. So Dr. Patel mentioned a few a moment ago. Probably the most, the one that folks know the most about and are impacted by most frequently would be prior authorization. And so prior authorization is where you get permission from a health plan or a pharmacy benefit manager before access to a prescribed medication is granted. Another common one that you've likely heard about is step therapy. This is also called fail first. And so this is where before access to a medication is granted, you have to fail or step through another medication before you're given the treatment that the doctor had initially prescribed. But today we're talking about non-medical switching, and it's funny, I even spoke the other day to a U.S. Senator's office about this issue, and they were not completely familiar with the concept of non-medical switching. And so, Beth, can you kind of level set for us? I'm going to let you take this slide. What is non-medical switching, and how does it kind of happen most frequently?
Sure. Well, non-medical switching is when an insurance plan forces a patient to change medications for reasons that aren't medical. So the most common would be there's a formulary exclusion. So the medication is completely removed from the plan's preferred drug list. It's completely not accessible as a covered drug. But the medication could also be simply placed at a higher coverage tier, making it unaffordable for the patient so that the patient has to switch drugs to a cheaper medication. In either case, the patient is forced to change medications from the one their doctor initially prescribed.
Great, thank you, Beth. I think that is a great level set on what switching actually is. Just some more technical characteristics on switching. Generally, what we see is that switches happen in the middle of a plan year, so around July, or we'll see them sometimes at the end of the plan year. Sometimes you'll hear about a grandfathered switch, which means patients who were stable on a medication are not immediately switched, but patients who are new to the plan that may be on something else are switched. And sometimes you need to get new blood work done or testing done, and Dr. Patel, I'm sure, could talk about this when a switch occurs, which obviously was very complicated during the pandemic. And we actually saw that you saw some of these utilization management protocols were kind of paused during the pandemic, prior authorization being one, but non-medical switching went on, which could be really dangerous if you have to get new blood work or whatever. It's very difficult at that time, at least, to get to the hospital or to a clinic to get that work done. And the real thing here, and we'll talk more about this shortly, but switching punishes patients who work diligently to manage their symptoms and their disease. And Dr. Patel will talk about this a little bit later as well. It can be incredibly disruptive for clinicians' offices too. So Patsy, again, can you give us kind of the high level, why this is happening? Why does this non-medical switch protocol occur? Why do the plans do this?
If I had to state one reason, it is the financial component. It is the money involved. Right now, there are lawsuits going on across the country against some of the PBMs or pharmacy benefit managers because of things they are not including on the formulary. They are not required. When you have a contract with a pharmacy benefits manager, they will get certain benefits. They are not required to reveal what the benefit status is. So at times they receive a larger rebate for expensive drugs versus ones that would provide better outcomes. And so some states are eliminating their PBM, some counties are, and some part of the federal government are eliminating those PBMs because of that reason. I want to give you a statistic. The top three PBMs combined made close to $20 billion in 1 year. Again, they're the middleman. And something as HR professionals we're going to have to do is to get the transparency, get things in our contracts that make them be transparent, and perhaps get things in the contract and get the attorneys involved where they can't switch in mid-year or they can't switch throughout the year.
Well, thank you, Patsy. And there's a comment here that was put in the chat that I'd like to just point out here. It said, someone submitted, they said at my old company, I had an employee with hepatitis C. The benefit provider switched him to a generic version that was not as good and in fact caused more costs for dispensing, et cetera. And as the employer, they actually went back and said, you need to give them the proper drug. And they actually did that. So first of all, I'll just say to this person, thank you for advocating for your employee. That's fantastic. But this is a real thing. It happens daily as we can see here, not just in the cardiovascular population.
Could I add something in there,
Yeah.
Ron? I think in the past, we have not communicated. We have got to become educated in healthcare as HR professionals, but we also need to educate our employees and have that communication between us so that we can fight the fight with our provider against the other entities that are doing it more for financial reasons versus the health reasons. Educate your employees to document, and then we can help write appeal letters for the physicians that they can then add to and submit to help us get those right medications in place.
Well, that document point, I think Beth will make that here in a moment too, Patsy. That's absolutely true. So, Dr. Patel, let me come back to you real quick. Tell us as a doctor why non-medical switching is bad.
Non-medical switching is bad because, simply put, the doctor, I think, knows what's best for the patient. Respectfully, I'm not sure the people at the PBMs are doctors who are really vouching for the patient. I'm a patient advocate. I do things for a reason. Every action has a reaction. When I make a change in medicine or when I change a generic to a brand, there's a reason for it. I respectfully have maybe new data, there may be new indications, there may be new studies, there may be new FDA indications, there may be new guidelines. And I have to say, sometimes the insurance companies lag behind the most recent and current research and studies that are out there. Great examples would be like cholesterol medicines. We had medicines for cholesterol that were absolutely blockbuster, causing a 60% reduction in cholesterol levels, but insurance companies decided that it was not really something that was an urgency, and it took literally, Ryan, as you are well aware, about a year and a half to 2 years for these insurance companies to come around. I mean, at these times, it's frustrating because I'm looking at the patient and telling them we have a possible new therapy which could be better, yet insurance companies are not embracing what's really right for the patient. And that's why it may be a financial gain for PBMs, but look, I'm an advocate for the patient. I'm in the trenches. I'm seeing 50 to 60 people a day with a team of 10. I want to do what's right for my patients because I truly believe that cardiovascular disease is not a cancer. It can be treated. And I want to say also, we're talking about cardiovascular disease. How many of us know someone that's had a stroke? How many of us know someone that's had a heart attack that shouldn't have had a heart attack? How many of us know a diabetic who may have lost a limb? How many of us know a patient that's had heart failure who keeps on going back into the hospital because heart failure is the #1 cause of readmissions into a hospital? A lot of these things, I think, can be prevented, not all, but a lot of this can be prevented with appropriate therapy directed by the patient and, of course, by the provider.
Can I ask you to speak to this slide real quick here, Dr. Patel? So in this 2019 study that we cite here from the Alliance for Patient Access, it says that individuals who are switched, 60% suffered complications. But I think the number here that I really want you to speak to is this 39% of patients stop taking their medications. Can you put a fine point on that, how dangerous that is?
Yeah, I mean, of course, patients stopping their medicines, it can be extremely dangerous. I mean, depending on what the medicine is. Something like, let's say, blood thinners for an irregular heartbeat, such as atrial fibrillation, the ramifications can be even a stroke. And, when we give blood thinners, we reduce the risk of strokes by 5-fold. So when that patient's not taking that medicine, let's say the blood thinner, the DOAC, they're walking on eggshells. These patients, you don't know what's going to happen and when it's going to happen. And unfortunately, Ryan, having done this for 20 years, I see a few of my patients end up in the hospital. Maybe they weren't taking their heart failure medicines because the insurance company put them back on a generic, or maybe they weren't taking the latest and greatest cholesterol medicines to prevent cardiac events. Maybe they weren't taking the latest diabetes medicines. I mean, diabetes has had a massive explosion in therapy, and they may now have very high sugar levels and have eyesight problems, kidney problems leading to dialysis, blockages in the legs leading to amputations. It's heartbreaking. It's heartbreaking. So I do feel that interruption of therapy can ultimately lead to events, because let's talk about this. We're not talking about one patient. If you have a group of 100,000 or 1 million patients, let's say you have diabetic patients with CAD and diabetes, that's 10 million people a year. You know that some of those patients are going to have some events if there's interruption in therapy. Mm-hmm.
Thank you. You touched on a lot of these things: efficacy, side effects, adverse reactions. Out-of-pocket costs can rise for patients as a result of these switches. So thank you for that, Dr. Patel. As you can see on this slide, there was a survey done by the American College of Physicians, and you can see that Dr. Patel's sentiment is widely shared among clinicians. The results of their survey you can see here on the screen. But the things that really I think to really focus on here is two major points. One is 80% are concerned that they're forced to take responsibility for their insurer's decisions. I'm sure Dr. Patel, you can relate to that. But this is the one I want you to speak to Dr. Patel. 84% reported increased administrative time dealing with insurers, keeping them from clinic time with patients. Can you put some context behind that for us?
Ryan, I think that's even 84% is very conservative. You know, every time as a provider, I make a decision, a clinical decision about a therapy, a lot of the time there is a lot of people in the background who are having to talk to insurance companies. I have two nurses who I presume take about 30% of their time doing pre-authorizations, talking to insurance companies, documenting why we're doing it. And I'll be honest with you, Ryan, as a physician, there is something called physician fatigue. I'm getting tired of not being able to do my focus and my love, and which is seeing patients, and really being diverted by all these quote other things. I give a therapy and the next thing it's denied because of X, Y, and Z. And the problem is that after a while, you start getting burnt out. When you're seeing this many people and you're trying to do the right thing, you kind of feel like you're hitting your head against the wall. However, once you introduce me to Patch, I feel that, you know, this is one of those platforms where we can reflect on the barriers that we have in dealing with these things, because at the end of the day, it should not be this difficult. I was absolutely impressed with what Patsy said about the amount of money involved with these mid-level PBMs. Goodness gracious, I wish we could use that money towards some other things in life, even patient advocacies and screening diabetics for PAD and screening people for blood pressure so they don't have strokes. But the point is very simple. In today's day-to-day clinical practice, doctors, nurses, and medical assistants are spending about 30 to 40% of the time when you don't see the doctor, dealing with all these paperworks, piles and piles of paperworks, putting information into computers. And really, I feel it shouldn't be that difficult, Ryan.
So Dr. Patel, there's a really good question here that came up in the chat that I want to throw to you. And then Beth, you actually might have something on this as well. But one participant asked, are generics not the same chemical compounds of the brand names? Generics have been approved by the FDA, correct? So can you speak to that, Dr. Patel, what we're talking about here in terms of generic versus brand, that kind of thing?
Sure. I mean, you know, there is nothing wrong with generic medicines, number one. This is not a competition of generic versus generic. We are talking about, you know, brand versus medical switching and brands. And the second thing is generics usually have been on the market for a few years before they turn generic. Well, let's talk about if there's a generic medicine out there, but there is something that is newer, which has new studies and new indications, efficacy, safety, which might be better than a generic. Then as a provider, I want to give my patient the latest and greatest. Of course, backed by FDA approval always. So no, generic is not always the latest and greatest. And great examples would be things such as in the cholesterol arena, there were injection medicines that lower cholesterol. In the atrial fibrillation arena, warfarin we all know about, which was used to reduce risk of stroke. We now have pill forms where you don't need to check the coumadin INR levels, which have been shown to be as good, if not better, than warfarin. So the point of the fact is, science moves on, technology moves on. However, not generic medicines are up to date. And so cardiovascular medicine and treatment is changing every single year with the latest and greatest. And I want to keep up with that so I can give my patients the best therapies out there backed by the latest and greatest science. So generic.
Oh, go ahead. Sorry.
So, you know, generics are great, but when you're living in 2022, what I treated a patient in 2022 is very different from a generic therapy I may have used in 2020.
Beth, can you speak to the generic versus brand conversation and what we generally see? And I know you'll speak to this a little bit in your comments, but I'd like to address this question here at the outset too.
Sure. I think for me, what it comes down to, especially with my condition, is medications affect each patient differently. And some medicines that may work perfectly fine in one patient may have different side effects in another patient. And so, for me, I want to be on the medication which my doctor says that I need to be on, whether that's a brand or whether that's generic. If I'm on a medication that's working for me, I would rather be on that medication than have my insurance company tell me which medication I need to be on, because there's usually pretty valid reasons why we have thoughtfully chosen that particular medication over another medication.
Beth, I think you said that really, really well. And I'll just give an example, like in blood pressure. Yes, generic medicines are great for blood pressure, but I also know if a patient comes in with a blood pressure which is way higher than it should be, in my mind, I already know I may try generics. It's just going to be a waste of time. I need to try maybe a brand name, which I know has more efficacy in reducing the blood pressure. But instead, what happens is I write the brand name, it gets changed to generic, and I already know the patient is going to come back in 2 weeks' time. Blood pressure will not be to goal. The patient is now disappointed that I gave them a therapy that did not get them to goal. And then I have to do the whole thing again and again and again.
Okay. Thank you guys for that. So Beth, let's we got you in here. Let's talk a little bit about your experience as a patient. So can you introduce yourself, Beth, to the audience, and just tell us a little about yourself personally, and then we'll get into your diagnosis and that kind of thing.
Sure. Well, I live in Chapel Hill, North Carolina, and I have previously worked in health program administration for the state of North Carolina and for the university here in Chapel Hill. And I currently spend a great deal of time working with the nonprofits and taking care, being a family caregiver. So like a lot of you, I wear a lot of hats.
So tell us a little bit, Beth, about your diagnosis and what you deal with on a daily basis.
Well, 18 years ago, when I was 34 years old, I was a healthy, busy mother preschooler, felt perfectly fine. And I just began experiencing some leg pain. And that was followed a few days later by some shortness of breath and some chest pain. I saw my primary care physician. We initially thought that my leg pain was probably just a pulled muscle, and my chest pain was probably a respiratory infection for which I was prescribed antibiotics. But it turns out it wasn't that simple at all. And a few days later, I had a near fatal episode when a blood clot broke off from my leg, traveled through my heart, and lodged in my lung. And that was the beginning of a 9-day hospitalization, in which, quite honestly, I almost died from that clotting experience. And I was diagnosed with deep vein thrombosis and pulmonary embolism, which are blood clots in my legs and blood clots in my lungs. And the question was, why would an otherwise healthy young woman develop blood clots out of the blue? And the doctors did some tests, and they discovered that I have a blood clotting disorder. It's a thrombophilia. And so I'm at high risk for developing another blood clot in the future.
Mm-hmm. So how do you treat this, Beth, this condition?
Well, I'm very, very lucky that there is an effective treatment that can prevent another clot. And I'm just so grateful that it's in the form of a simple pill. It's a blood thinning medication, an anticoagulant. But because I do have the clotting disorder, I'm going to need to be on this medication for the rest of my life.
And what's the possible consequence if you are not on it?
Well, because of the clotting condition, my risk of developing another clot is about 18 times greater than if I did not have the clotting condition. So basically, my blood really, really, really wants to clot. So if I were not on this medication, I think it would be a matter of not if I developed another blood clot, but probably when I develop another blood clot. So it's absolutely crucial that I follow my doctor's instructions and I take this medication exactly as it's prescribed, so that I can prevent another blood clot in the future. And that's why at each and every appointment that I have with my doctor, we review my medical history we check in to see what's going on, to see are there any new concerns that I have, what are my risks for clotting, what are my risks for bleeding, and we evaluate, am I on the correct medication at the correct dosage? And over the past 18 years since I had that clotting episode, my health has evolved, and so therefore my medication needs have evolved. And so that's been changed over the years. But for the last 8 years, I have been stable on the same brand of blood thinning medication.
So spoiler alert, Beth, you experienced a non-medical switch. So tell us about that.
Yes. In November, I received a letter from my insurance company's pharmacy benefit manager informing me that the medication I had been taking for the past 8 years was no longer going to be covered, and I was going to need to switch to another brand of medication. And that was it. The letter did not even contain a phone number to call if I had a question. It did not mention there being an appeals process. It simply said, contact your doctor and ask for a prescription for this other brand of medication. And that if you don't do that, you're going to have to pay the full retail price of the medication you're currently on. And I was just completely shocked. I had no idea that my insurance company could step in and essentially change the blood thinning medication that I had been on for the past 8 years, over the one that my doctor had recommended.
So Beth, help us understand how widespread this switch was.
Well, I wasn't the only one who received this letter. I think nationally there were around 150,000 other patients like me. And not just patients who were at risk for my type of blood clot, but also patients who were at risk for stroke. So nationally, there were around 150,000 cardiovascular patients who received similar letters to be switched off their brand of blood thinning medication.
So Dr. Patel, let's get the clinician perspective. Help us understand, how dangerous it may be to switch an anticoagulant medication, or what your fear as a doctor is if a patient is forced to switch their anticoagulant medication.
Sure, as Beth has eloquently mentioned, when someone has a bleed or clot disorder, switching means that there may be time in between where there is no therapy. Maybe Beth has to wait for the new medicine possibly. And of course, in that gap between one therapy and another, there's certainly a risk of an increased risk of the clot. So that is concerning. And as a provider, whenever a switch is made of any type, we have to kind of make sure that the medicines are gelling with the medicines that, let's say, Beth's already on. So it becomes a bit more complex. There can be drug interaction issues that we may need to discuss. And as Beth mentioned before, it depends on the patient and what works for them. Some medicines are once a day, some medicines are twice a day. I mean, it depends on the patient. So I don't think, it's a matter of X versus Z. It's a matter of the fact that what worked for Beth and, trying to keep her on the therapy that was working for her.
And I would also point folks back to the slide that we had earlier that said that something like 40% of patients stop taking their therapy. And in the anticoagulant space in particular, that can be very dangerous when folks stop taking their anticoagulant medication, because in Beth's case, you will start to clot. And Beth, this happened in North Carolina because your plan is one of the larger ones in the state. Can you tell us a little bit about that and what happened with the North Carolina plan?
Right. Well, my health plan covers state employees and teachers and university employees in North Carolina. And this is around 750,000 employees that my plan covers. And of that, there were just over 5,000 patients who were had their blood thinner switched on my particular insurance plan. And this was effective January 1st. Because my plan is public, a lot of the meetings are also public. And so in February, in a meeting of my plan's Pharmacy and Therapeutics Committee, it was revealed that 2 patients who were forced to switch blood thinners had suffered thrombotic events, clotting events. And so my plan voted right there that evening and voted to put the blood thinner back on the formulary. And so I was fortunate that I was able to get covered access again, but only because there had been adverse events.
Absolutely. So Beth, to just wrap up your section here before we move to Patsy, Patsy mentioned earlier, document. That's maybe one piece of advice you'd have for folks, but what other advice would you have for folks on staying on their medication if something like this happens to them, since you've been through this?
Well, I would say the first thing is absolutely document, but contact the insurance company. Find out if there is an appeals process and what that appeals process is. And you will most likely need to work with your physician to file some sort of paperwork, some sort of prior authorization to be able to stay on your medication. The other thing is contact the pharmacy and find out what the cash price is of the medication. Because depending upon the cost, it may be that you make a decision that can you budget it in to just simply be able to pay out of pocket and not even file it on insurance. And the third thing is to contact the pharmaceutical manufacturer of the drug you're taking and find out if there's any patient assistance programs. A number of drug manufacturers have coupon cards and rebate cards and copay assistant cards. And I personally found that very helpful to help me be able to afford the cash price of my medication for those coverage gaps so that I didn't have, as Dr. Patel mentioned, those few weeks of being off an anticoagulant to where I would have to pay the full retail cost of my drug.
That's great. Thank you, Beth. Patsy, I want to bring you in here to kind of tie a bow on this to a certain extent. I guess I'll just kind of open the floor for you initially and just say, what are your major takeaways for the HR folks that are on the line about what you've heard so far?
One is, did you ever think 2 years ago that you would even be on a call like this? And the importance of starting, if you haven't already, but knowing the importance of being educated on the healthcare component of your business, how that affects your employees, how it affects your direct cost. Right now, the healthcare cost of your company, the direct cost, is typically number 2 on the line item of your P&L statement. Those are the direct costs. That does not affect the indirect cost. When I'm talking about indirect cost, I'm talking about the additional time that employee has to be off for these other treatments or figuring this out. It doesn't take into account how it's going to affect the project management stuff you have going on. If this person is responsible for customers and they can't be there, so look at all of the indirect cost. As a side note, I want to mention also something that Beth just mentioned when she said, are there discount cards, et cetera? Up until about 2 years ago, there were pharmacies who had gag clauses. They could not tell you if there was a cheaper way to get your medication. So going back to a statement I made earlier on, get educated, get your employees educated, find out about, are there cheaper ways to get the medication? Become that, your employee and your physician now, you're a new team. And the only way to change this ship that is, I think, based significantly on financial is to work together, because we want the health of the employee, we want the financial component of the employee, we want the financial component of the business. But what it comes down to is that physician is the trained person that knows the medical needs. And we need to work in conjunction with that trained person. I would also say, even considering, we've known in the past that our employees not being educated on leadership, on project management, whatever they're responsible for, has an effect. So get your employees educated on the cost of healthcare, what they need to know. I know there's one company that they've provided things in the past. I've teamed up with them, and I'm going to mention their name not to say to bring them in, but to say that the importance is so significant. the training that is being provided to HR professionals, this speakers you need, they have now said, this is so important. We have a separate arm devoted to educating HR professionals. I would say do calls, have routine calls with your other HR professionals across the nation and have this as a topic of discussion. Get that input from employees. Do you have physicians in the community like Dr. Patel that occasionally could be on those calls to educate you, to help you fight for the employees that affects your productivity, your company, and the lives of the patient?
Patsy, there was a question earlier about the fact that many plans are self-funded by the employer and they're trying to keep costs down. And honestly, you know, this is, I'm sure, even more relevant now with inflation. We're headed towards potentially turbulent waters when it comes to the economy. Got a tight labor market. You know, there's a lot of competition for talent. There's a lot of pressure to maintain bottom lines. What's the economic argument for strong coverage policies in your mind for people with chronic disease that may be employees of some of the businesses on the webinar?
We are now seeing employees who will come to a company and who will stay with a company primarily because of the health benefits versus the salary. So if we can strengthen that, become more educated in that, we will draw more employees, we will maintain more employees than many other companies because it is such a significant component of people's lives.
Talk a little bit, Patsy, about how benefits managers can advocate for their employees. I mean, we actually heard one attendee talk about this a little bit. But how would you advocate for your employees?
Go back through the documentation, but I would have, I would find out, how do your employees get the cheapest prescriptions, like the things that Beth just mentioned? Are there employee benefit cards? Can you do a comparison? I know there's one item that I've looked at that you can put in a zip code and you can drive within 10 miles and find $150 difference on one medication. Well, I found that out because I've been doing research, but most individuals, most of our employees, and most of us as HR professionals would not know that. So I think we need to bring in those kinds of things and just make this a part of our routine education for our employees.
Dr. Patel, one question here that's in the chat that I wanted to throw to you real quickly. One attendee asked, a lot of folks say that physicians have a favorite drug provider or favorite drug and lean toward that particular medicine when they're actually less expensive options that are available. You know, any comments on that? Anything you could say that? And actually, Dr. Patel, can you speak? I mean, we've talked about this before. Talk to us about how you have to consider the cost component of these things too, yourself as a clinician.
Certainly. I mean, yes, you want to always provide the best therapy at the lowest cost, no question about it. And, you know, I have to, every single time I write a generic or a brand, I have to think about what that will mean for the patient, even generic. You know, there is nothing wrong with generic medicines, but unfortunately, as mentioned in this talk, generally speaking, the latest technology type medicines are not generic. And so, you know, it's a fact. Most of the most recent medicines for diabetes, heart failure, irregular heartbeats, these medicines are not generic. And that, respectfully, it's taken many years for those medicines to come and be researched. And so, you know, unfortunately, they're not generic, but they're mostly guideline driven by many societies like the American College of Cardiology, etc. And I think that as providers, yes, we do have some habits. Of course we do. We all have our own different habits and how we drink Starbucks, etc., etc. But we do try, for the most part, to be understanding of the patient. And, you know, if they cannot afford medicines, we do go to generics. There's no question about it. But at the same time, what's frustrating is when I feel a patient strongly needs a therapy and they are not able to get it because of costs or other factors that we've discussed on this talk.
Yeah, and I would say to this, thank you, Dr. Patel, for that. I would say to this attendee too, you know, just keep in mind that what we're talking about here a lot of times is the forced switching, and this could be brand to brand, brand to generic, but sometimes the doctor is not even notified that this has happened, right? And when that happens, A lot of patients stop taking their medications. And it's really dangerous. And we would advocate from a policy perspective, like if I was in front of a state legislator or a U.S. senator, that there needs to be some guardrails around this or notification at the very least. If we were trying to find compromise on something like this, ideally we don't want folks switched at all. But if we were trying to find some compromise, there needs to be much better appeal processes and notification of these things, because we found there was a survey we did recently of a number of cardiovascular doctors, and they said they found out from a pharmacist that this switch had happened. And as with these anticoagulant medications, that's incredibly dangerous. The patient goes to the pharmacy counter and they're being given something that they've never been prescribed by a doctor. Would you take that? It's a serious concern. So thank you for the question, though.
Well, and Ryan, I think just to add to what you and Dr. Patel have said, my particular switch was I was switched from one brand of medication to another brand of medication. There is no generic available for my particular medication. And those two brands retail for about the same price. So it's not always a brand to generic switch. It can be a brand to brand switch, simply because the insurance pharmacy benefit manager, it has got some type of arrangement with one company to prefer one product over another. And that's not always transparent.
Absolutely.
Could I add one thing also? And that is, Ryan, you mentioned when you talk with legislators, as companies, as small businesses, as organizations, don't be afraid. Make it a point to pick up the phone, call your legislators, your congressmen, make them aware of this. And I'm going to suggest something that maybe we haven't thought of, but if you have an employee that's willing, or you as a company are willing, go public on the news media. Put pressure on these, because we want transparency and we want the best outcome for the patient.
Yeah, if we had another hour, Patsy, we could go into that too. Beth has a lot to talk about that as well. Absolutely. Thank you. Well, we're getting here to time. Dr. Patel, Patsy, Beth, anything you want to impart on the audience to wrap things up here?
I just think it's always about the patient, Ryan. That's what it is. Every day you go to work, it's about the patient and the best thing you can do for the patient. And so I feel good about what we've discussed here, because at the end of the day, we are the patient's voice. Beth is certainly a unique individual, but unfortunately, for the most part, we are the patient's voice, and it's great to reflect some of those ideas on this discussion today.
Thank you, Dr. Patel. I'll just leave with you all. If you are interested in more resources or would like to connect with us about these cardiovascular health issues, you can go to our website, advancedcardiohealth.org. We have their policy papers and a number of different educational materials that talk about these issues and many others. If you'd like to talk to Dr. Patel or to Patsy or to Beth individually, we'd be more than happy to connect you with them. And just first of all, finally, just want to say thank you so much for joining today. We hope that you learned something and that this will help inform your practices as HR professionals. And if there's anything that we can ever do to help you or connect you to clinicians or patients that know a lot about this work, we're here as a resource. So please don't hesitate to reach out. Thank you so much for your time, and have a great day, everyone. Thank you.
Thank you.
I'd like to thank our presenters as well as all of you for joining us today. If you'd like to view this webcast again, the archived recording will be available on the hr.com website within 24 hours. The webcast credit will show in your hr.com account within 2 business days, and we'll also send you an email with your credit information. Your feedback is important to us. Please take a moment to fill out the exit survey that opened in a new browser page on your computer. This concludes our webcast. Enjoy the rest of your day.